So I've been tasked to speak to you about obesity in pregnancy, which, as Uma just said, it's something we are facing as a big challenge for us in the obstetric world. That's me. So I work as a college as a senior vice president, but I also lead in something called the maternal medicine networks. And in the UK now, as we started with having cancer networks, we now have medical problems network, because we realize that a lot of women do not necessarily have equal accessibility to good care depending on their postal code. So the aim is that we have few hospitals gathered together. For example, I chair the South West London and Surrey Heartlands. There's about 8 hospitals I look after, and to make sure that the protocols are the same and that women, wherever they are, they can have equal access to good quality care. So what is the problem at hand? So we know that the prevalence is high and it's increasing day in, day out. Recently, the WHO described it as a global epidemic, and we know that since 1975, the obesity rate has nearly tripled. So some of you who have been practicing for a long time like me have noticed that over the years, we are now seeing more and more women with a higher BMI that we've ever seen before. And therefore, this now becomes a key health issue for us in pregnancy. In the UK, we have something called the Embrace report, and the Embrace looks after both maternal and fetal outcomes in a form of mortality and morbidity, and is done every 3 years. And the most recent report have clearly shown, yet again, like every 2 years we have, that obesity plays an important role in maternal mortality outcome. We have noticed that women with a BMI of 35 or above have a higher risk of dying during pregnancy and childbirth. We also know that there is a higher risk of complications of stillbirth and neonatal death, and that also the complications of pregnancy, maternal complications, such as preeclampsia, diabetes, postpartum hemorrhage, etc., are also increased with the BMI above 30. There is no doubt in our minds that we definitely need to find a proper form of intervention of how we manage these women and how we can improve outcome in pregnancy. So let's remind ourselves about the maternal and fetal risks of pregnancy. So miscarriages go up. We know that preeclampsia and pregnancy-induced hypertension go up 6-fold with a BMI above 30. Gestational diabetes, similar. We also have an increased risk of thromboembolic disease. And some of you who do fetal medicine realize that there is a problem with ultrasound difficulties, especially if you look after women with a BMI of 70 and 80, it becomes really difficult to have clear vision of the baby. There are intrapartum risks. You are aware of things like difficulty in delivery, therefore the higher prevalence of dystocia, cesarean section, instrumental deliveries. Anesthetic risks are really serious, especially if you don't have a good regional anesthesia service, and the surgical difficulties as well as postpartum hemorrhage. Following birth, we now know there is an increased risk of detachment from the baby, increased risk of lower breastfeeding, and as well as VTE, such as DVT and pulmonary embolism. On the baby, there's a high risk of congenital abnormalities, stillbirth, but this is the area that I'm interested in, which is childhood and adult obesity. So we now know that babies of obese women have a higher chance of them developing hypertension, diabetes, cardiovascular disease as adults. And the question is, can we really break that cycle and improve the outcome? So let's look at gestational weight gain, because there's a lot of studies, as you can see here, around the world, looking at the impact of reducing gestational weight gain in pregnancy and whether that will also have an impact on the pregnancy outcome. And actually, there are some form of interventions that have shown some improvement in gestational weight gain, Because we know that if you start with a BMI, let's say of 30, and you have less weight gain compared to someone else who started at the same point, this person with a lower weight gain during pregnancy will have a better outcome, both maternal and fetal. The question is, having that less gestational weight gain, does that translate in better pregnancy outcome? I.e., do we have less preeclampsia? Do we have less gestational diabetes? Do we have less PPH? Do we have less cesarean section? And I think at this stage, it doesn't seem that link to be clear. And these are different studies from around the world. As you can see here at the bottom right, there is from Brazil. There is on the bottom left, there's some from Tanzania. So we have from Africa, from China, from the US, from the EU, from India, and lots of interventions, unfortunately, seem to show that the gestational weight gain, although can be impacted somehow with certain interventions, that doesn't translate very well in improving outcome significantly. There's been lots and lots of money spent around the world looking at other interventions such as dietary and lifestyle changes. One of them, very well-known study in the UK, known as the Upbeat study on the right there. And that's actually cost millions of pounds. And that's where women with a high BMI were randomized across London in given clear advisory on their diet, absolutely clear program of exercise, but the findings were disappointing. There was no change in outcome. The LIMIT study, the LIP study, the ETIP study, all these big trials, very big trials around the world, have shown zero impact on pregnancy outcome despite all these interventions. And at the bottom there, there's also behavioral interventions about giving people sessions about how they eat, etc. Also very disappointing. So what do we do? Do we bury our heads in the sand and say, look, we're just obstetricians. We only have these women for 9 months, probably less than 9 months, because by the time we see them, they're already 12 weeks pregnant. And they say, this is a governmental problem. This is a public health problem. Can we do something about it? And do we have any interventions? Now, bariatrics is very interesting. I'm not talking about bariatrics during the pregnancy, but pre-pregnancy. Just to remind ourselves of the bariatric surgeries, gastric bands. I now know from my colleagues who I work closely with in the bariatric services that very rarely they put gastric bands. Actually, as a matter of fact, in the UK now, they're removing more bands than putting them in. Gastric sleeve is becoming a very popular surgery. So this is, I think now, is the leading surgery in the UK. There is a mini gastric bypass, we call it the loop bypass, and of course the big one, which is the Roux-en-Y gastric bypass. So if a woman has had this surgery before pregnancy, does it really improve pregnancy outcome? And the answer is yes, but there is also some concerns. So we know that it reduces gestational diabetes, it reduces preeclampsia and delivery complications, and that's a good thing. So if you have someone you manage to catch between pregnancies or they see you pre-conception, it's not a bad idea to offer them interventions such as bariatric surgery. Of course, this does not have to be modified with the emergence of GLP-1s and GLP-2s, the Mounjaros of this world and Ozempic of this world, which is actually changing the whole way how we practice bariatrics. But interestingly, that despite some women BMI go back to normal, they still have an increased risk of intrauterine growth restriction. And I see here some of our fetal medicine colleagues like Diogo and Asma Khalil, they might probably have a view on that, whether that's because of macronutrition, but despite that, there is that risk, and therefore you need to keep an eye on the baby's growth very, very closely. There is also an increased risk of preterm birth when you compare the BMI for the like BMI as well as the preterm rupture of membranes once they've had the surgery. We tend to recommend people to wait for about 1 to 1.5 years after surgery, and important to advise them about contraception and use the right form of contraception. Now, What about drug interventions? I was listening yesterday in this very same hall about rejuvenation and regeneration kind of science. And metformin is a drug of real interest to a lot of us. So metformin is a plant, actually. It's been around for thousands of years. And actually, the first time it was mentioned as a possible benefit in health is actually from my homeland in Egypt, where the pharaohs were describing that metformin was used if you boil this leaf and give it to people who have polyuria and polydipsia, it improves outcomes. And I'm assuming polyuria and polydipsia, that's diabetes. And actually, it's really interesting that it's been since there. But actually, Professor Jean Stern from Paris is the first person really to make a real kind of strong interest in metformin and named it glucophage, which means glucose eater. That's where the name came from. And there is considerable evidence of its safety in pregnancy. But we need to remind ourselves it's a small molecule, and therefore it does cross the placenta and go to the baby. Now, do you think that metformin may have a benefit with regard to obesity? So on your left column there, you can see the pathogenesis that happens with obesity, insulin resistance. Metformin improves insulin resistance. Everybody knows that. Hyperglycemia, it reduces hepatic gluconeogenesis. We know with obesity the inflammatory changes. Metformin has an anti-inflammatory effect. It has a weight reduction effect, as well as it reduces serum insulin and improves lipid profile. It improves endothelial function, and that's really interesting, and that's why it has an impact on the cardiovascular function as well as hypertension. As you can see here, it looks like a marriage made in heaven, isn't it? It's a fantastic drug to really research as a possible use, as an innovative use in obesity. A big trial called the Empower trial, led by our colleagues from Edinburgh, what they randomized women being given metformin up to 2.5 grams versus placebo, randomized at booking, and looking out for primary outcome, which is the birth weight centile. And unfortunately, they found there was no difference between the baby's weights in both groups. Interesting, at the same time, I was leading a big trial with my colleague, Professor Nicolaides from the Fetal Medicine Foundation and the Harris Birthright. But our difference was started actually recruiting people from booking as well, but we're using up to 3 grams. And we went for a BMI of 35 rather than 30, because my view was that if we go for a higher BMI, then there will be a higher possibility of more pathology. And I think the metformin would work better when people have a higher insulin resistance and higher inflammatory changes. Our primary outcome was, can we reduce the birth weight of the baby by 0.3 standard deviation, i.e. a 40% reduction? We knew most likely no, because even with the Dutch and the Irish famine data, there was no huge impact on the baby's weight. But we said, let's see if that will have the impact. And then, of course, we have looked at secondary outcomes. Interestingly, and disappointingly, there was no difference in the primary outcome. So there was no difference in the baby's weight, which wasn't a surprise. But then, interestingly, we found that is a 27% less weight gain and a 76% less preeclampsia. And that was really interesting to note. The question is, does that mean giving metformin to obese women at the start of the pregnancy bring down those gestational weight gain as well as preeclampsia? I think the answer is we need to do a trial, because this is a secondary outcome and it was empowered, but I think it probably will have a role. And this is the paper we published in New England Journal of Medicine, and that's the reference here for you. Now, the next question for me to ask was, why did this happen? Why not gestational diabetes, but preeclampsia? Because we all expected that the metformin would have an impact on gestational diabetes. So we wanted to look at the insulin resistance. And if you can see here that between the metformin group and the placebo group, there was a clear difference in the insulin resistance, significant. But when we looked at the preeclampsia and the non-preeclampsia, there was no significant change. And we published that paper a year later, and our conclusion was that it is not an insulin effect. It must be something else. And I think that's really quite important for us to acknowledge. So in conclusion, obesity is a global epidemic. There is no concrete recommendations in pregnancy apart from having this multidisciplinary approach that we currently do. Diet and physical exercise intervention studies so far have been quite disappointing. I think there is evidence that you can reduce gestational weight gain with some interventions such as metformin, but the question is, can we really have an impact on the outcome? And I think we need more trials on the metformin intervention. And then last but not least, I think it looks like we can now see with everything else. We need to think a little bit differently, that not every woman with a particular BMI will behave exactly the same as the other BMI of a similar one. We need to find a model that is smart and intelligent and see how we can predict these changes and who will benefit from metformin, who will benefit from metformin and exercise and diet, and who will benefit from other different models. So I think the jury's out at the moment, but I think it's an important question we have to think about. Thank you very much.
Thank you. Thank you so much, Dr. Hassan, for focusing on such an important subject, something we're dealing with on a day-to-day basis. And even in countries such as India, which were basically historically undernourished women and, underweight women, nutritionally deficient, even in India, we are facing a huge epidemic of obesity. And unfortunately, we don't even have, women coming for preconception care. Because if we have an obese lady coming much prior to her pregnancy, coming for preconception care, we can put her on a diet and exercise program. We can put her on medication, maybe to help her lose weight, and then to plan pregnancy with a more ideal weight. But unfortunately, that is extremely rare in our country. And so we have to do the best that we can in her pregnancy, dealing with the obesity. And we do use metformin, but like you said, the effects are questionable. So thank you so much for focusing on this very important subject.